Okay, so this is a quick explanation of immunodeficiency disorders. First, some generalized point differentiating B cell defect and T cell defect. B cell defect present after 6 months because till 6 months mother's immunoglobulin provides protection, and T cell defect occurs since birth. In B cell defect, the same thing. B cell defect, the infections that we get are shin, Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis. Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. And in T cell defect, we get all sorts of infection, viral and fungal. Okay. Then, first, it's severe combined immunodeficiency disorder. It is one of the most severe form of immunodeficiency disorder. It is a T cell defect and it is present since birth. Okay. So, X-linked. It can be of two types: X-linked recessive and autosomal recessive. ADA deficiency is autosomal recessive. Interleukin 2 receptor defect is X-linked recessive. A for A, and X-linked X second, interleukin 2 receptor. Here germinal center will be absent, and JAK3 also can be JAK3 gene defect and REG12 gene defect. I don't know if these are X-linked recessive or autosomal recessive. It is not mentioned clearly. Clinical features: SCID, severe combined immunodeficiency disorder. So will be in a child. There will be morbilliform rash, candidal infection, diaper rash. Okay, rash, child infection. Then comes Bruton hypogammaglobulinemia. Bruton tyrosine kinase defect, B. Bruton hypogammaglobulinemia is all B. Humoral immunity is gone. Cell-mediated immunity is intact. B for boys, seen in boys. B cell defect and BTK and Bruton hypogammaglobulinemia. Decreased immunoglobulin G. Defective opsonin. Opsonin defect, so phagocytosis will be impacted. Sinopulmonary infection with enterovirus and giardia. Okay. Then Bayer lymphocyte syndrome, MSC2 defect. Not much is written about it. DeGorge syndrome. DeGorge, we need to remember. On the rest we will remember. The only thing we need to remember is in long arm of chromosome 22, and it's a T cell defect and defect in third and fourth pharyngeal pouches. And we get cleft lip, cleft palate, tetralogy of Fallot. Rest we will remember only. Hyper IgM syndrome. In hyper IgM syndrome, CD40 and CD40 receptor and CD40 ligand defect. Isotype switching does not occur. We need for MD to become GAMD, we need CD40 receptor and CD40 ligand. So here MD will not become GAMD, and we will get pneumocystis xerovecii pneumonia. Then it is hyper IgE syndrome, Job syndrome. Ma'am gave a mnemonic. In third world states, it is the fate of 17-year-old boys to get a job. In third world, like we say third world countries, in third world states, it is the fate of 17-year-olds to get a job. Job syndrome occurs in 17-year-old, that is in adolescence, and in 17, Th17 defect. Then the presentation, there will be abnormal faces, that primary teeth will be retained, and there will be abscess and eczema. Wherever we have increased IgE, there is eczema. High IgE eczema in hyperimmunoglobulinemia or Job syndrome and Wiskott-Ulrich syndrome. And complement deficiency, Neisseria infection, chronic granulomatous disease, NADPH oxidase defect, catalase positive organism. Then Chidiac-Higashi syndrome. The buzzwords are albinism and dense granules. The mnemonic is LMNOP, least gene defect, light, that is albinism, least gene defect, light albinism. Microtubule defect, neurodegeneration. Phagolysosome phagolysosome defect, phagocytosis will not occur properly. Platelet count low, neutrophilia and dense granules. Then isolated IgA deficiency. IgA will be low. Washed RBC are given in transfusion. Wiskott-Aldrich syndrome. This is the mnemonic. Wiskute boy is wearing a tie. Wiskott boy, X-linked recessive, wearing, wasp chain defect, wearing tie, thrombocytopenia, infection, eczema. IgE will be increased, so eczema. Decreased IgM level, increased IgA and IgE. So this is exactly the opposite of hyper IgM syndrome, where MD does not become GAMD. This is the first pro B cell, then mature B cell, then plasma cell, then IgA deficiency. Pro B cell, Bruton tyrosine kinase make it mature B cell, buff make it plasma cell, then IgA. BTK gene defect, Bruton A gamma globulinemia. This is also an X-linked recessive disease. The other X-linked recessive disease is Wiskott-Aldrich syndrome, X-linked recessive. This is about a boy, this is about a boy. In SCID, interleukin 2 receptor defect is X-linked recessive, and Job syndrome is also about a boy, so I think it is also X-linked recessive. Then Bruton tyrosine kinase, since this is a B cell defect, after 6 months there is no immunoglobulin whatsoever, absent immunoglobulin, absent germinal center and tonsil. Tonsil also have B cell, so absent, and absent B cell. Because tonsil is also absent, because tonsil have B cell. Then pro B cell, mature B cell, plasma cell, IgA. Mature B cell to plasma cell, buff defect. If buff defect, chronic variable immunodeficiency. Here the germinal center will be hyperplastic. In adolescence, seen in adolescent, low IgE, IgA and E. Low A, G and E will be low, IgM will be high. Plasma cell to IgA, IgA defect. IgA is a mucosal immunoglobulin. Due to its defect, giardia and anaphylaxis on blood transfusion may occur. Thank you.